Thank you. And so, backed by popular demand, Dr. Mount, I'm going to get you up on stage again. And so she requires no introduction. And so Dr. Mount is here to talk about palliative care in hematology. And so learning objectives, this is to discuss barriers to palliative care implementation at end of life for patients with hematologic malignancies. And so in terms of the case check-in, the patient now presents 2 years later with constitutional symptoms and shortness of breath. Imaging shows a large pleural effusion and widespread lymphadenopathy. Axillary lymph node biopsy confirms disease relapse. Patient undergoes additional therapies and were given polatuzumab with bendamustine and rituximab, lenalidomide and rituximab, but only short duration of response. No curative options are left available locally, and he will need to travel to the US for a clinical trial as a potential option. Still, he recognizes his functional decline and grim prognosis. And so, question to consider, when should palliative care be involved in patients undergoing active treatment? One of the interactive questions here includes, what is the most common symptom for hematology patients in the end of life? Choose one. And so we have fatigue, pain, anxiety, depression, and fever. And so for this, fatigue is the most common. However, there are variations to this, and Dr. Mount will take us through it. Here.
I think I talk too much with my hands and I move my head around, so I've got this. No. It's good? Can you guys hear me?
Yeah.
Okay, great. As I said, I think I use my hands a lot. I also have no pocket, so I have nowhere to put this. Thank you. So bear with me. So as Dr. Pua, obviously you already heard my introduction. I'm a hematologist at Victoria Hospital. I do primarily inpatient care, and I have a passion for palliative care. So I want to take the last 10 minutes of this hematology day just to touch upon palliative care in hematology, because there's probably not as much as there should be. I'm hoping that we can have a good discussion about how we can do better. And just out of curiosity, how many people here are involved with palliative care or do their own palliative care? We've got one hand. We've got two hands. I'm hoping there's lots of hands at home. So let's get started. So nothing to disclose. And the one extra objective that I just wanted to touch upon is we're not just going to talk about the evidence for early integration of palliative care with hematology patients, but I also want to provide my own approach to how you have end-of-life conversations surrounding blood transfusions with our patients, because I think that's a very difficult conversation to have. And so I've got a couple of pointers, as it's something I do routinely up on the floor. So a couple jokes with some truth. And I'm going to come back and kind of hopefully go over why these jokes exist, and maybe share a little bit of wisdom as to why this may be the case, okay? So from my initial presentation, I talked about DLBCL being aggressive, curable type of lymphoma. But I guess the question is, what happens to those patients who don't respond, that extra 12% who may be, or 20% that don't respond to initial R-CHOP chemotherapy? And this is a great schematic that I like to see, that you can, you don't need to read the fine print, but you can see multiple lines of therapy as these patients relapse or are refractory, all the way from perhaps going through with intensive chemotherapy and autologous stem cell transplant. Patients will go on to CAR T-cell therapy, and so on and so forth as the lines go on. What happens in real life, though, for these patients who are refractory or relapse? We have the SCHOLAR-1 trial, which came out in 2017. This was an international retrospective study looking at those patients who were either refractory to R-CHOP or who relapsed after second line or within close proximity to their autologous stem cell transplant. And what they found is that overall, their prognosis was very poor. So we're looking at around 6 months. Now this, I will have, there's a caveat, this was before CAR T-cell therapy. But the take home here is that if you relapse after your initial therapy, prognosis is very poor. How do we provide palliative care to these patients? Well, there's a great palliative care group out of Mass Gen who took a look over 20 years of data of elderly patients with aggressive non-Hodgkin lymphoma and saw of the patients who passed away, what were some of, how did they get palliative care near the end of life? And probably none of these numbers surprise people that almost 3/4 of them were actually admitted to hospital within the last month of their life, that a third received chemotherapy and a quarter were in the ICU. And when it came to where they received their end-of-life care, the majority received that in hospital. So I guess the question is, we know that their overall survival for if they don't respond to therapy is extremely poor. So why are these patients not receiving palliative care? Why are these patients dying in the ICU? And I bring your attention back to this graph because I'd say one of the major problems with a lot of the cancers that we treat is that the line when we switch from curative intent to palliative intent is not always clear. And I would beg you to ask any of the oncologists here as to which line of this therapy for this, say, one individual, is it curative intent or is it palliative intent? And really with DLBCL, as we've talked about, even those patients who do relapse, cure is still possible, even in the later lines of therapy, although it may not be successful. If you do palliative care, you know this trial. This was a landmark trial out of the New England Journal of Medicine in 2010, looking at non-small cell lung cancer patients who were randomized to early integrative palliative care versus standard care. And if you recall, those patients who had early palliative care had better quality of life, less depressive symptoms. They had less ICU admissions at the end of life, and the big take home was that there was a survival benefit for those patients getting palliative care. We're fortunate that the same group kind of looked at AML and tried to use early adaptation of palliative care in those patients and found very similar results. Those AML patients with palliative care had better quality of life, less psychological stress. They were more likely to have discussed end-of-life preferences with their caregivers. And they were less likely to receive chemotherapy, but if you note, still over a third received chemotherapy in the last month of their lives. So what are the barriers to palliative care in this patient population? Prognostic uncertainty. So I kind of touched upon that with that schematic of the different lines of therapy. It's not always sure which patients are going to respond to therapy. A lot of these curable intent type of diseases like DLBCL, we still try and treat to cure patients. And so it's very difficult to have end-of-life conversations or conversations regarding palliative care or end-of-life when the intent is still hopefully to cure you. Compared to our solid tumor colleagues, we see a lot of rapid deterioration in our patients at the end of life. Patients can present in tumor lysis or DIC or hyper viscosity, leukostasis that Dr. Saini had touched upon, and be in hospital, and things kind of unravel all at once, and we don't have time to have those meaningful conversations about what they would want. This is a talk all on its own, maybe at a later time, about patients' expectations and oncologists' expectations when we know that outcome for a lot of these patients is very poor. However, we're still hopeful that they will be that 1% that will have the good outcome. And because of the prior three, we don't like to talk about hospice. We don't like to talk about palliative care necessarily and take away hope. And so these conversations don't happen until the patient is imminently dying within the last hours to days of their life and they're admitted to the hospital. And then the system-based barriers. I'm going to personally talk about blood transfusions as a barrier to palliative care and hospice, but other things like hydroxyurea, steroids, antifungals, antibiotics, things that we routinely have our hematological patients on that are not always acceptable to go to hospice with or other palliative care units in the community. So what can we do? Well, we can have better goals of care conversations. This was a palliative care group out of Dana-Farber that looked at 400 patients with hematological malignancies. And they were specifically looking at what was special about that first goals of care conversation. Were there features of it that resulted in better outcomes for those patients? And what they found that if you had a goals of care conversation within at least a month before the person died, in an outpatient setting, so not in the ICU, not on the hematology ward, and if you had a hematologist present, you were less likely to wind up in the ICU within the last month of your life. Now, I'll make note that it says hematologist, though the authors also said it could have been anyone that the patient trusted from a healthcare profession. So as hematologists, we're extremely privileged to have relationships with patients that can span years. Sometimes we see these patients every week, every month. We have these life and death conversations with these patients. We bring them back from the brink of death. And so they instill in us a lot of trust. However, that could still be a relationship that the family doc of 30 years has. The emerge doc who's looking after that patient coming in with Feb-Newt every single month, or the hospitalist or GPO that's looking after them at the satellite chemo that sees them once a week for their Velcade. So of special note is just in that study, like how few of this actually occurred. And I see a lot of heads nodding because this doesn't come as a surprise to a lot of people. So let's talk about blood transfusions. So for our leukemia patients, blood transfusions are very, very important if you've ever tried to take away a blood transfusion from a leukemia patient. There's good evidence and studies out there that show that at the end of life, fatigue is overwhelmingly the symptom that patients worry about most. Not pain, which is usually a primary symptom that sends someone to hospice or have a PCOT team following them, and that they value their blood transfusions far more than any of those other kind of symptom management controls. In the US, they polled a bunch of hospice providers, found about 3/4 of them agreed that not having blood transfusions in hospice or other palliative care unit settings was a barrier to these patients getting adequate palliative care in the community. And actually ASH, which is our big American society, has come out with a number of statements endorsing hospices in the US to provide palliative blood transfusions to their patients. So what are the barriers? Well, it's costly. Blood is really expensive, and it's expensive to pay for the nursing support for that. The safety, a lot of our patients, if they're getting transfused twice a week, they develop antibodies. And so it's not as safe to provide that blood without rigorous testing. And how do you manage for blood transfusion reactions? And lastly, the futility portion. Blood is a very valuable resource, and it is a finite resource. So for a lot of people, it's very difficult to wrap their head around giving a bag of blood to someone who is in the last days to weeks of their life, when that could be spent on someone having a postpartum hemorrhage or someone who's just come in as a trauma. So how do I have conversations with my patients regarding stopping blood transfusions or continuing them? I kind of cheat. So I have early conversations with patients. Every single leukemia that comes up on the floor that I get my hands on, I have a conversation at the beginning to say, you are going to get a lot of transfusions over the next coming weeks to months. That's going to become part of your norm. It's going to become a habit, but there will come a time when they stop working. And so that they are aware that there will be a conversation in the future where ongoing blood transfusions are no longer viable for them. When I'm having an end-of-life conversation with a patient who's on transfusions, I then start asking them, how do you feel after your transfusion? Because I'll usually hear two different stories. I'll either hear, you know, when I first got diagnosed and I was getting transfusions, I felt awesome. I used to feel so good for like a week, but you know what, doc, now I don't feel good. I feel no different than I did before. If anything, I feel more tired because it's exhausting dragging my butt out of bed to come here to get my transfusion and then come back home. For those patients, it's easy to say they're not working. You're only going to get more risks associated with it. It's time to stop. But then I also have other patients who say, you know what, I still feel good after them. Like I still feel like I have enough energy to play cards with the kids, or to sit up all night and chat with my partner, or at least spend the majority of the time in a chair and not passed out in a bed sleeping. And for those patients, I consider doing palliative transfusions. And the way that I do that is I do a CBC, because I need to make sure that they're actually anemic. If your hemoglobin is 100, you're not going to benefit from a unit of blood. But then I target symptom. I don't target the number afterwards. So they get a unit and we reassess. How do you feel? Do you feel like you have more energy? Yes, great. We end it there. If they don't, then we stop. And patients can wrap their head around there. It's a big transition getting away from the numbers. But when you're really transitioning to that, we're just going to make you try and feel as good as possible for how long you have, then they're okay with if this is something that has to stop. So big take-home messages, relapse in most of our diseases is abysmal. We are seeing patients being able to live for a couple more months, sometimes short years. But for any of these patients, it's probably appropriate to have palliative care in the background, even with any of the active therapy, especially for AMLs. We have some good evidence that early palliative care is beneficial. It improves quality of life and reduces chemotherapy in the last 3 days of their life, and that it can reduce ICU admissions if you have a good goals of care conversation, if you know your patients. And ideally, it would be, as I point to my hematology colleagues, one of us, but if it's not, that one of you guys as well. And lastly, just to think, maybe the next time I have a patient up in my ward in a community hospital, that maybe this patient would benefit from a palliative transfusion, but maybe they wouldn't, and just feeling like you have a bit of a framework maybe to go off of to have those conversations. Any questions?
Any questions for Dr. Mount? One from the floor. And so what are barriers that you encounter when trying to provide good palliative care in our community in Southwestern Ontario?
Ooh, good question. So blood transfusions are not acceptable at hospice here in London. Parkwood PCU generally does not do them either. We're fortunate we have the PCU unit here, say here, one floor below us at Victoria Hospital that will sometimes consider it. Our PCU in the hospital will also sometimes continue antimicrobials if it's for symptom management. So someone with rip-roaring C. diff, you probably don't want to take off their PO Vanco because no one wants to have that at the end of life. There is a discomfort in some way with, or not maybe a discomfort, an unfamiliarity with dealing with a lot of heme patients, I think for palliative care doctors in general, because you don't see a lot of them. As I say, a lot of our patients end up dying in hospitals, so they're on drugs or therapies that are very unfamiliar, and they're not your typical breast cancer, colon cancer at end of life, where pain is an easy one to try and manage. But our symptoms of fatigue and high rates of depression and anxiety can be difficult, and I think patients of ours just feel more comfortable being in hospital for that.
Thank you. Thank you.
We have a question.
Yes, Dr. Matusa.
Yes, comments. Yes, discussion.
So University Hospital does the same. So even people admitted on the palliative care unit at University Hospital, we can do, we're okay with transfusions for symptom management, fatigue, dyspnea, and community. So I work in community, part of one of the palliative care teams, and we are okay with that as long as we get the support, because it's more difficult for me to organize a blood transfusion. But if we're working together, you guys organize the transfusion, the patient comes there and all good. Hospice, by definition, you don't go there if you want to have those treatments. But the same, like for symptom management, for dyspnea and fatigue in the community, so patients who want to stay home and can stay home, that's doable.
Yeah, that's great to hear. And ideally, that would be the case. A lot of our patients are quite unwell at the end of life. And so being at home, although they don't get a lot of time to spend there, that would be the benefit of early palliative care, hopefully, to try and maximize time at home. That's where a lot of people would like to spend the majority of their time. But no, that's great to hear about at UH as well. So thank you.
Okay, thank you, Dr. Mount.